All right, in this episode, we are going to talk about shock. Uh, no, not that kind of shock. No. Oh, good Lord, no. Okay, yeah, that's a little better. All right. So let's talk about shock and let's talk about the different kinds of shock, the different types of shock, the different styles, the different ways that shock can affect the body. So normally what we've understood of shock is we've thought of shock as relatively simple. So we've kind of said, all right, it's compensated, it's decompensated. Not sure why I drew the eyes first. And then it's irreversible shock, right? So we've always kind of thought of it in that way. It's one, or it's this, or it's that. That's still kind of true, but there's a little bit more to the story. So the little bit more to the story is that shock actually is more of a continuum. Okay? So if you think of shock on a continuum, what you think of is you think of a person who is not in a shocky state whatsoever, and they're sort of at, that higher end of the continuum, maybe way up here. They're not in any type of shocky state at all. Maybe they were injured, but, it didn't cause any type of shock. But then, if there was some sort of injury that could be potentially causing them to go into shock, they will start to dive on this continuum. Okay, so they'll start to kind of go from one area, that compensated area, to that decompensated area, to finally that irreversible area. So what I sort of say is, I don't think that calling something irreversible shock is that great of an idea. Okay? I don't think calling irreversible shock is that great of an idea. Yes, the book will call it irreversible shock. Even ITLS will say irreversible shock. That's dead as far as I'm concerned, or very near to death. So I'm always going to try to fight that fight. I'm always going to try to beat shock. I'm always going to try to win. I'm always going to try to take and reverse that patient's fortune and bring them up into that area of a compensated shock. Okay? So the old way of doing this, the old idea here was, let's just get ourselves a bunch of fluid and let's just dump as much of that fluid as we can into that patient, right? Because they need fluid. That's what they need. We just have to get more fluid. And the more fluid that we can get into the patient, the better that we can make them feel. And oh, I got another. Let's put their feet up on some books. Yeah, because if we put their feet up on something, then all of the blood is going to rush from their feet to their head. And we want to perfuse the brain. And so we're going to get all of that blood to go up to the brain. Well, that doesn't work. All right, let's talk about some of the things that do work. Let's talk about some of the potential solutions in terms of shock. And I guess if we want to talk about solutions, we have to talk about the types of shock first, because you can't talk about solving the problem until you talk about the actual problem. So let's talk about the first type of shock. And I think the one that probably everybody thinks of when they think of shock: hemorrhage. Did I spell that right? Don't know. Don't care. Okay, so hemorrhagic shock. What is going on here? And I think of it in terms of buckets. Now, you know me with drawing. When it comes to drawing a bucket, that's about as good as it's gonna get, guys, okay? You gotta have some imagination, and you gotta go with me on this. And this bucket is filled with all this special fluid, all of this blood. There's blood in that bucket. And then someone comes along, and lo and behold, they put a hole in the bucket. Oh, no. All right. So what do we do? Yeah, I think it's pretty obvious what we do, isn't it? It's pretty obvious. We have to plug the hole. If there's a hole in the bucket, then all we do is come along, and with something, we plug the hole. All right, so we've got the hole plugged. That's great. But they did lose a lot of blood, and so we want to make sure that we can still get perfusion up to the squash. It's all about perfusing the squash. It's all about making the brain happy. That's what we want. We want a happy little brain. And in order to get that way, what do? We just, well, let's go back a couple of slides. What do? We flood them with fluids. Something tells me that's not going to work too good either. Okay, well, we do need to do volume replacement. I don't think there's any doubt about that. We need to do volume replacement. So we need to put some fluid in there, but we do need to be a little careful. What we don't want is, now that we've got that hemorrhage blocked, we've got that hole blocked, what we don't want now is to come along with all of that fluid and start flooding that patient more and more. Okay? We don't want to do that. So we are going to talk about a term called permissive hypotension. As my dog is over there coughing on something. So we're going to talk about a term called permissive hypotension. Permissive hypotension, or permissive hypovolemia. You may hear it said that way as well. So permissive hypotension, permissive hypovolemia, either one. We are going to talk about that term. And the idea here is that if we have a patient who is hemorrhaging, if we have a patient who has hemorrhaged, then we want to try our best to keep them from continuing to hemorrhage, or worse yet, bleeding out faster. So we have the choice. We can either have that patient bleed out slower, or we can have that patient bleed out faster. Well, that doesn't sound like a good choice. No, that's not really the choice. The choice here is, what is the best treatment for the patient? So in a permissive hypovolemic state, generally what you'll see is that the book defines it as sort of a 90 systolic. And there's a lot of books and a lot of articles out there that talk about 90 systolic, and that's fine. 90 systolic is kind of correct, but it varies. It varies from patient to patient. Patient A, 90 systolic may be fine. Patient B, 80 systolic may be fine. And patient C, 70 systolic may be fine. And patient D, 110 systolic may be the requirement for them to have adequate perfusion to perfuse this guy. Okay? So if we want this guy to be happy, then what we're going to have to do is we're going to have to find that state that works best. Because at the same time, if we have stopped the bleeding, that's great. We're probably in an area where we're okay. But if we have a patient that's bleeding internally, something like that, we may not have the ability then to say, all right, I know exactly how much they've bled out, and I know exactly how much fluid I then have to give. So you're going to have to look for those signs and symptoms. Well, let's talk a little bit about the signs and symptoms in terms of hemorrhagic shock. So what we've always kind of accepted in hemorrhagic shock is that early on in the continuum, and again, I'm always going to draw shock on the continuum. Early on in the continuum, we see that the patient's heart rate is elevated, right? Their blood pressure is probably normal. And maybe we've got a respiratory rate that's slightly elevated, okay? And that's sort of a patient that is compensating, right? Because if you remember what I drew a long time back now, I guess, what was it? Way back in December, that cardiac output equals stroke volume times heart rate, okay? So if my patient is bleeding, then my stroke volume is decreasing. And so what's the body going to do to try to compensate? Well, it's pretty simple. It's going to try to increase heart rate. So if it increases heart rate with a decrease in stroke volume, we keep cardiac output the same, and this guy stays happy, okay? So as we start to see this patient move down the continuum, okay, we may see that their blood pressure may start to drop a little bit, okay? And that right there, that is going to be the dividing line for us as to whether or not this patient is in compensated or decompensated shock, right? Well, don't just rely on blood pressure. That's not the only thing that tells us that the patient is going into decompensated shock. No, of course not. There are plenty of things that come in between, right? And one of the things that really tells me whether or not my patient is starting to decompensate is their level of consciousness. Their level of consciousness. When I start to get that patient who starts to become confused or sleepy or lethargic, any of those kind of things, that tells me that very soon that patient is going into decompensated shock, or that they're already, kind of on that edge of decompensated shock. Okay? And one thing, if I want to, I want to kind of go back, and I want to make sure I state that early on in all of this, okay, at the very beginning, you may have a patient, even though they're injured, in a non-shock state whatsoever. Okay, they may be way up here at that upper end of the continuum. They may be sitting right up there, very happy, perfectly fine, seeming absolutely normal, and then they start to go into compensated shock. Okay, and that's where we usually start to see an increase in heart rate. The blood pressure may remain normal for a little while. The respiratory rate may increase. And then eventually we start to see some mental status alteration. And eventually that blood pressure is starting to drop. Maybe that heart rate, oops, I'm drawing that in red. That's okay, though. I guess I can do that. Maybe that heart rate is continuing to go higher and higher. Okay, maybe over here, let's say that they were at, I don't know, maybe 102, right? And then over here, what I'm starting to notice with this patient is maybe they're in the 120 range. And if you look at your ITLS book and even the Brady book, they do mention 120 for our heart rate as sort of being, sustained now, as sort of being that dividing line as to whether or not my patient is really starting to decompensate, starting to get worse. They sometimes, you'll see them even reference it as sort of that area of compensated shock, but leading into decompensated shock. Okay, that sustained heart rate of 120 is usually one of my markers. Okay, so a lowering blood pressure, a sustained heart rate of 120 or greater, those are sort of my markers saying, hey, the patient may be in compensated shock at the moment, but they're certainly heading into decompensated shock. Okay, as they continue to decompensate, well, what's going to happen to the heart rate? Well, the heart rate is going to drop. This is a very ominous sign, very, very ominous sign. This is really bad. When I notice that heart rate is dropping, that tells me that my patient is not only in decompensation, they are in late decompensated shock. They are now going into that area where things are getting much, much worse, okay? And again, this is all without treatment, right? Because if you're treating them and their heart rate's starting to decrease, well, that's good. We want that. But this is no treatment. This is not talking about any treatment at the moment. This is simply saying we have that patient, we haven't treated them, their heart rate is starting to drop, and that's really an ominous sign. That's something that really makes me worry, because not long after that, we will see that blood pressure start to bottom out. Okay, and that's when we know we're going to start going into heart arrhythmias. We're going to start, that we're not perfusing the brain. We have a very unhappy brain, and that patient is starting to drop on us. So what do? We come along with our IV. All right, so let's talk about IV fluids. The answer to how much IV fluid do I give is always the same: enough to maintain peripheral perfusion. If I am maintaining peripheral perfusion, I am maintaining perfusion to the brain. That's what we're talking about, okay? Enough to maintain peripheral perfusion. Now, yes, we can keep that patient in a permissive hypotensive or a permissive hypovolemic state, but we still have a patient who is perfusing peripherally. So the answer is always enough to maintain peripheral perfusion. You can add to that. You can say things like 20 cc's per kilo, but enough to maintain peripheral perfusion. It's always going to be the same. It's always going to be the same. Okay? So how much fluid do I give? Enough to maintain peripheral perfusion. That is the ultimate answer. So sometimes what you'll see on tests, not necessarily on one of my tests, but sometimes what you'll see on tests is you'll see something like some sort of question like, your patient is a male patient, he has injured his arm, he was bleeding profusely, the bleeding has now stopped because of direct pressure that you have applied, and the patient's blood pressure is 80 over 40. And the question is, how much fluid should this patient get? And inevitably, what they're asking you to do is they're asking you to say, okay, well, 20 cc's per kilo, and that's how much fluid I'm going to give my patient. 20 cc's per kilo, and therefore, if the patient is, 100 kilograms, then I am looking at 2,000 liters of 2,000 liters. Wow, that'd be a lot. 2,000 cc's of fluid, 2 liters of fluid. Give me 2 big bags and the large bore and all of that kind of good stuff. No. The problem is, now that you've gotten that bleeding to stop, let's say it was an arm, and you've gotten that bleeding to stop, and you start to increase their blood pressure more and more and more and more and more, you're going to cause them to bleed out. They're going to blow that clot back out. You stopped it with direct pressure. Maybe you'll have to put a tourniquet on. Maybe you won't. But the other problem is that you're going to come into is you're just going to overflow this patient with fluids. You're going to flood them, and that's not the ideal situation for a patient like this, for a patient that's injured. Okay, so when I want to add one little tidbit to this, one little thing that I need to add to this, and that is, when your patient has a head injury, that's going to be different, okay? We're going to talk about that in the head injury chapter, but when your patient has a head injury, you actually want to increase the amount of fluids that you have. You want to increase the systolic blood pressure. You want to actually keep it above 110 systolic. Now, some of you may actually be looking at this thing right now with that, kind of cockeyed look like, wait, what? It's true. But we'll get to that in head injury. We'll talk more about that when we talk about the head injury chapter and why that is. All right, so let's talk about a different type of shock. Let's move on from hemorrhagic shock, because I think we've beaten that horse to death. Let's move on to neurogenic shock. And I'll give you a second to look at this. And you can see neurogenic shock. Basically, the problem with neurogenic shock is that we had a tank, and that tank was, a certain size. So here's our tank. Okay, we have a nice tank over here, and it's filled with this magic fluid over here, right? And let's say that that magic fluid is about 5 liters. So there's 5 liters worth of fluid in there, which is approximately what we as human beings have in our body, except when we're pregnant. Well, not when we're pregnant, but when women are pregnant. That will increase to, about 6, maybe 7 liters. Maybe not quite that much, but generally in that 6, maybe 7 liter range. Maybe, not quite 7 liters. You get the idea. Anyway, so what happens here is in neurogenic shock is simple. Neurogenic shock is what we call a high space shock, or a relative hypovolemia, okay? And the problem is that the liters haven't changed. The liters are exactly the same. That 5 liters is still 5 liters, hasn't changed, but the size of the tank got bigger. And so therefore, the amount of pressure that's able to go up and perfuse that brain has actually decreased. Okay, for firefighters, think about it in terms of if I had a nice sized hose ready to fight that fire, the right size hose. I don't know the size of the fire hoses, but you get the idea. You have a nice size hose, and then someone comes along and they attach a hose where the lumen is 5 times bigger. Okay, well, what happens? You lose pressure. You have to increase the pressure over on the pump end in order to continue to get enough pressure out in order to fight that fire, right? So this is a situation, neurogenic shock is what we would also call a high space shock. High space shock, okay? So what can we do in this situation? That's the question. Well, this is one of those situations where volume replacement is not necessarily a bad thing. This is a patient where I can put that 20 cc's per kilo into them. That's a possibility, right? Go ahead and put that 20 cc's per kilo in. I replace that volume. I basically add to the tank, right? So I take and I just add some fluid there to the tank, and that pressure increases again, and now I can get some perfusion to the brain. So yes, that's a possibility. The other possibility is to try to make the tank smaller. Now that's something that we may be talking about down the line. Right now, I don't think it's in any protocols or anything like that in the state of Wisconsin. And nationally, I'm not aware. I know there are some studies and some experiments. There may be a couple places out there, maybe you can find them, that are actually using pressors in high space shock. I think it definitely shows promise. There's a good possibility that that may actually come into ITLS in the next update. Right now, ITLS talks about it, they sort of mention it, but they don't really say, this is a patient and you need to be giving pressors for these patients. But, now with norepinephrine coming into Wisconsin, there is that possibility that we may see that. So in other words, I just take and I make the tank smaller, and once I make the tank a little smaller, then I can get better pressure up to the brain. And now I have a much, much happier brain, okay? So that's what we're talking about in terms of neurogenic shock. Generally, we could be talking about a spinal shock where there's some miscommunication completely between the brain and the adrenal glands, and so we don't have all of those nice stimulants for the sympathetic nervous system to go out there and help out and create vasoconstriction. Or we could be talking about something where it could be just some sort of overall loss of space. Again, high space shock. The other thing, and thinking about, and this is why I kind of stalled for a second there, is thinking about high space shock. Sepsis is a type of high space shock, right? Sepsis is a type of high space shock because we're talking about some leaky capillary issues there, and that's actually sort of a high space shock. So in those type of patients, when we're talking about a patient who could be suffering from a septic shock, those are patients you definitely want to give fluids to. You definitely want to give fluids to a patient who is septic, because that really is the problem with your septic patients, is that they are relatively hypovolemic. The other thing could be maybe a drug overdose, some sort of drug that causes that patient to then go into some sort of high space shock. But I think in general what we're talking about here is more of a neurogenic style high space shock. So let's not muddy the waters too much. Let's try not to confuse them too much. So the other type of shock that we want to talk about is we want to talk about sort of an obstructive kind of shock. And I generally will try to, when I teach obstructive shock, I generally try to talk mostly about cardiogenic. A cardiogenic style shock. Now, the cardiogenic shocks, they generally present the same way as your hypovolemic shocks present, because really what the problem is very similar, okay? In your hemorrhagic shock, right, your cardiac output is affected by a decrease in the stroke volume, okay? That decrease in the stroke volume, but the reason that there's a decrease in the stroke volume is because there's less blood. Okay, less blood makes that decrease in stroke volume. In cardiogenic shock, we could be talking about something that's preventing that normal stroke volume in the heart. Could be that the heart is diseased, so congestive heart failure kind of thing. It could be that there's some sort of obstruction, so we're talking about something like a tension pneumothorax, or not so much a hemothorax, but a tension pneumothorax or a cardiac tamponade. Okay. So what we have, the problem that we have generally when we're talking trauma and the cardiogenic shock, we're not necessarily talking about congestive heart failure, is we're talking about something that's creating some sort of a squeeze on the heart, okay? The heart is being squeezed, and that squeeze on the heart is causing the heart to pump less efficiently. So what's the squeeze from? The squeeze could be from these guys that are sitting out over here, and I'm going to draw really bad lungs here, by the way. Your lungs are just squares. You didn't know that, did you? Yes, everybody's lung is just 2 squares. Okay, so you've got these lungs out here, and one of these lungs deflates. One of these lungs pops. Here, let's try to draw that. Boy, that's going to be fun, isn't it? Let's erase part of that. And we can just do a little bit over here. Yeah. And then, oh, yeah, there we go. Oh, yeah. Okay, so that lung has deflated. And so now inside of the chest cavity, I've got all of this air in there. And that air inside the chest cavity, increases the pressure and increases the pressure and increases the pressure and increases the pressure on the heart and on the great vessels. Mainly on the great vessels. Mainly, the problem is that inferior vena cava and superior vena cava, we get a lot of pressure on that great vessel, and so that drops preload. And of course, you remember, the Starling curve and preload, afterload, all that kind of stuff. So what happens is we start to get this drop in preload. And when we get a drop in preload, we get a drop in, you guessed it, stroke volume. Okay, so we get a drop in stroke volume, and therefore what happens is heart rate goes up to compensate. When the pressure gets high enough that the heart rate cannot compensate, then the patient begins to decompensate, plain and simple. So the treatment here is to come in, and I've got my nice needle here, and this is not going to look anything like a needle, but you get the general idea here, is that I'm going to come in with my nice needle here. I'm going to poke a big old hole in the chest, big enough for air to escape, and that air is going to start coming out of that needle. That's exactly what it looks like. Don't question. That air is going to start coming out of that needle, and it's going to start deflating that tension pneumo. And really, there you go. There's your treatment. The other option is, if I'm talking about something like a tension pneumo, what I have then is this pericardial sac that's sort of covering the heart, and blood or fluid has gotten into that pericardial sac. And because that blood or that fluid increases inside that pericardial sac, the pressure on the heart increases, and as the pressure on the heart increases, the stroke volume decreases. And so what do? Well, you guessed it again. I come in here with a needle. It's a little longer needle this time, and I poke a needle in there, and I get that blood or fluid or whatever is in there to come out, and that decreases the amount of pressure on the heart, allowing the stroke volume to increase again. So that's what I'm going to potentially do in cardiogenic shock. If you have a patient who has suffered some sort of an insult to the chest, a hit to the chest, or even a hit to the back, something like they fell backwards out of a moving vehicle or something like that, right? They've taken that hard hit to the chest, to the back, something like that. Think to yourself, there's always that possibility that something is going on inside that's causing this stroke volume to change, okay? Maybe I can't see it. I don't see any bleeding out. I'm checking their abdomen. I'm looking at all of those things, and I'm not seeing any bleeding out. And so therefore, I think what's actually going on here is that this patient is in some form of cardiogenic shock. Maybe I should think tension pneumo. Maybe I should think cardiac tamponade. The interesting thing in your tension pneumos and your cardiac tamponade is the jugular veins that are running right down the neck, and I'm not going to try to draw a neck because that ain't going to go. They start to distend. They start to get bigger, and they start to get bigger, and they start to get bigger, and they start to get bigger. And that's one of the things that really tells me that this patient may need some intervention. What intervention? Well, we're going to talk about that when we get to the chapter on thoracic injuries. But jugular vein distension is sort of one of my hallmark signs that I have some sort of pressure inside the chest that's causing the heart not to be able to refill. And so that means that blood is backing up into the brain, and that's making the brain very unhappy. Okay? So the other thing I could be talking about here is a hemothorax. Now, here's the thing. There is a little theory on the idea that, well, what if enough blood gets into the chest cavity that it actually increases the pressure inside the chest cavity enough to do sort of what that tension pneumo did and exert pressure on the heart? Yeah, I think by that point the patient's probably bled out or they're very close to it. The other thing that I would not notice, I would probably not have, is I would not have this jugular vein distension, okay? I'm not going to have that jugular vein distension because in this case, I've lost so much blood that the chances of those jugular veins actually being distended are very low. Okay? So, although theoretically speaking, if there were enough bleeding into the heart or into the chest cavity and causing enough pressure on the heart, that, yeah, it could, I guess, compress the heart enough that the heart would not be able to get enough stroke volume. Yeah, I just think by that point your patient is bled out, and, that's a completely different problem. Well, what do you think they're going to do about blood in here? Well, we're not going to necessarily do anything about it, but the doctor's going to come along with a bigger tube, a bigger needle, and he's going to start a chest tube on this patient. Okay? And all of that blood is going to drain out. That's the idea. Get it out of there and decrease the amount of pressure in there. But really, they're also going to have to go in and find out where that bleeding is coming from. If the bleeding is enough to cause a massive hemothorax like that, it's very possible that the patient is not going to survive regardless of how many tubes you put into them. This is a patient that's going to need some sort of surgical intervention. So the last shock that I'm going to cover here today is going to be anaphylactic shock. Now, you talked about this in medical, so I'm not going to go too much into it. I'm not going to, beat this up too bad. This guy's... That sounded kind of bad. No, he didn't get beaten up. He is in anaphylactic shock. This gentleman here is in anaphylactic, in having an anaphylactic reaction. Whether or not he's actually in anaphylactic shock, I'm not 100% sure because he's a cartoon. But there are some good signs. I don't know, maybe the fact that his tongue is sticking out because he can't keep it in. And then you notice that his eyes are kind of swollen, and I guess so. Never mind. So let me just clear that. Sorry. Got away from myself. So this guy is in anaphylactic shock, okay? Or there's a possibility that this guy is going into anaphylactic shock. Well, anaphylactic shock is another sort of almost kind of like a high space shock. The patient winds up getting leaky capillaries. They wind up vasodilating. And, there's multiple reasons. The physiology you went over in medical, there's multiple reasons why these patients have these leaky capillaries, all about histamine and all of that kind of stuff. But we don't need to go into that right now. What we're going to talk about is we're going to talk about what happens with these patients. And so you sort of see where their blood pressure, let me clear this drawing out real quick. You'll sort of see where their blood pressure will drop, okay? Their blood pressure will drop. Their heart rate might increase because if stroke volume is dropping, then the heart rate will generally try to increase in order to keep the brain happy. And, hopefully it works. But what we really have to do is we have to come along and we give them a medication that vasoconstricts. We give them a medication that opens up their airways and allows them to breathe better, okay? So this is the trauma chapter. So again, not going to talk too much about anaphylactic shock, but I just have to mention it. Obviously, you would say, well, wait, there's other types of shock too. There's psychogenic and septic and all of that kind of stuff. Again, not going to go too much into those. Just wanted to make quick mention of them. And, we want to continue on with that, the trauma chapter itself. So let's talk about some of the old versus some of the new. Now, usually when I show these, most people giggle because they think to themselves, like, how old are you? Those are mast trousers or pneumatic anti-shock garment. I've never even seen those things. Some places carry them, but I heard they're like really stupid. They kind of didn't work. They worked for healthy individuals, but they didn't necessarily do what we expected them to do. But you know what? Every time I teach a refresher, or even sometimes when I teach these trauma classes, I show this, and everybody's just like, yeah, okay, whatever. It's Trendelenburg, sure. This is just as effective as this. As a matter of fact, this might be more effective than this. Trendelenburg position. Oh, please get rid of Trendelenburg position. You'll notice it's been taken out of most books. It's not even mentioned in your Brady book anymore. It's not even mentioned, except to say it probably doesn't work, in most of the books anymore. So Trendelenburg position is kind of a myth. Originally, what Trendelenburg position was designed to do, Dr. Trendelenburg, who was an abdominal surgeon, a pelvic surgeon, said, you know what? In order to view the pelvic organs easier, if I take my patient and I tilt them, then all of the other organs will sort of go up towards the chest, and I'll be able to see the pelvic organs better. A brilliant, brilliant, wonderful idea. But then a doctor right around World War I said, well, wait a minute, if we did the same thing with a patient who's injured and potentially, hypovolemic, if we take them and tilt them, would we also, we should then get some blood to go up to the brain? Yeah! No, it doesn't work. So the really definitive studies on Trendelenburg, what they show is that when you put a patient in Trendelenburg position, when you put their legs up, you do get about 20% venous return. And you think, well, wait a minute, that sounds good. I get 20% venous return. So I get a 20% a 20% fill of the inferior vena cava. So that must mean that is going out to the rest of the body. No, it doesn't. It doesn't translate to cardiac output. So what was found in these studies was that that 20% vena cava return that we did actually get some blood flow return. It did not translate to cardiac output, mainly because there was now an increase in pressure on the heart. And actually what we found is that not only did it not increase the blood pressure and the cardiac output at all, but what it actually did is probably decreased it slightly and made things a little bit worse for breathing. I mean, if you've ever put a patient in Trendelenburg position and they're having some sort of an airway issue, it kind of makes it worse. A lot of times you'll get these patients that'll say, can you please put my legs down because I'm having a really hard time breathing. So what I always tell my students is Tootsie Rolls or Trendelenburg. Either one is going to be just as effective at treating shock. One is actually kind of nice. Now I think I need to go get a Tootsie Roll. Anyway, Tootsie Rolls or Trendelenburg, either one is just as effective at treating shock. So guys, start looking for the other ways that you can treat shock, right? We know we can talk about some fluid replacement, we can talk about some volume replacement, as long as we're careful and we're looking for that volume to be enough to maintain peripheral perfusion. Now, what happens if we flood that patient with fluids? Well, besides the possibility of bleeding out quicker, the other problem that I have is that I can actually send that patient into a hyperchloremic state. Hyperchloremic acidosis. Now, it would take a while to do this. It would take somewhere in that 3-liter range. But let's be honest. How many times have you seen somebody set their IVs to wide open, turn around and start doing other things, completely forget that the IVs are set to wide open, and the IVs are flowing and flowing and flowing and flowing and flowing and flowing, and before you know it, there's 2 liters into the patient, and they're like, well, let's put another one in. The blood pressure's not quite where we want it to be. Okay, so there is that possibility of sending that patient into a hyperchloremic state. Okay, so we need to be careful about that. All right, so what are some other solutions? Well, when we're talking about neurogenic shock, we already said we might have pressors. We might be able to use some pressors, and that might actually help us out. And then there's always the possibility of using TXA, tranexamic acid. Okay, with tranexamic acid, the key here is give it as early as possible. Okay, give it as early as possible. You want to go ahead and get that TXA in there. The idea with TXA is sort of to stop the breakdown of the clot. Okay, to stop that breakdown of clotting. All right, so we want to try to get it in as quickly as possible if we can. Right now, I know of, I think, 2 places that are carrying TXA. Not that many. I know the military obviously has been using it for a long time, and they've been getting some really good results out of it. And keep in mind, pretty much everything that we know regarding trauma comes from the military. The reason we know the things that we know is because of the military. Obviously, the other idea, stop bleeding, we can do tourniquets. Tourniquets are great. Please make sure that you put a tourniquet on if you notice that your patient is bleeding beyond your control. Okay? It is okay. The old idea was that, oh, well, if you put the tourniquet on, that's it. That arm or leg or whatever is dead from there on down because we've killed it. Well, not necessarily. What we found is that you can leave tourniquets on for hours and actually still see that you can reperfuse that patient. You can do that. You can reperfuse, not the patient, but you can reperfuse that extremity. So don't be afraid to do that. Obviously, if you carry blood on your truck, that's probably the best idea, is to give blood. But most of us don't carry blood because you have to keep it refrigerated. It's relatively hard to do that. But you may be able to call the bird, and they may come out and have blood there. So think about that. Obviously, the best fluid to be giving that patient is whole blood if we're able to do so. Okay? Some other thoughts or some other possibilities. I will leave some of that up to you to think of, and maybe, throw some questions back at me. What could we potentially do for some of these patients? What are some of the solutions? What are some of the ideas? What are some of the things that we could do? Even, I don't know, hint, hint, quick clot. We could be talking about some sort of hemostatic agent or something like that. So feel free to shoot some ideas back at me. Feel free to shoot some thoughts back at me. Let me know what you think might be some good ways to keep a happy brain. And guys, that's what it's really all about. Keeping this guy right here happy and healthy. And we can do that for our patients. We've talked about the solutions. We've talked about the ways to do it. We've talked about the ways to recognize shock. Think of shock as a continuum. Don't just think of it as my patient goes from one to the other to the other. It is a continuum. You can win. You can bring them back up on that continuum. That's what we're here to do.